Thank you, Dr. Sindis. Thank you, GIS, for the fifth great conference. And it's getting bigger and bigger every year, and we appreciate everybody involving in this conference. So, at the end of this bifurcation session, I'm going to talk about the physiology and imaging, about the, which is just perfect time that we have the biggest trial on a bifurcation OCT just recently published 2 months back. So I have no disclosure. My objective today is to go over the intravascular imaging and physiology in a bifurcation lesion. Then we're going to discuss some recent trials on the role of the imaging and bifurcation specifically, and the practical approach at the end of the session, just to have more practical. We all know that OCT, IVUS works, but not everyone is able to use them for different reasons. So before we start, to assess the bifurcation, either you can do anatomic, assessment or a physiologic assessment. As we all know, the physiology is IFR and FFR being the most popular. I think 90% of the interventionalists are leading toward the IFR because it's just faster and easier. But for the anatomy, we have either angiography or imaging, which is IVUS OCT. The benefit of the imaging is better stenosis severity and anatomic burden assessment. For the physiology, it will give you more of a hemodynamic and functional disease severity. So this is just to lay a ground. I'm going to talk first about the physiology and bifurcation. This is a very, very nice, well-written statement, by the Korean, Japanese, and the European bifurcation about physiology, specifically in the bifurcation disease. And a second one that I published just this year about practical physiology in general, not specifically about the bifurcation. So the first concept I want to discuss is the clinical relevance. What do you mean when you say a bifurcation? There is something called clinical relevance of the bifurcation. It is very complex. I cannot pretend it's going to be easy to assess the side branch. But in general, our aim is this going to have symptoms after we jail the bifurcation? Is it going to be an arrhythmogenic potential or the ischemic burden of that side branch? So multiple studies assessing non-invasive as well as invasive method to define the side branch relevance. So this is, a couple studies done specifically on the bifurcation, mainly with CT coronary angiogram. And the bottom line is only 1 in 5 non-left main side branch supplies more than 10% of the total myocardium, which is basically, we're talking about 20% of the PCI being a bifurcation. Out of those 20%, you're going to have 1 in 5 significant side branch that you probably need to take care of. So, another concept that we need to discuss is the ischemic depth and width. So to evaluate the benefit of the revascularization, we have to have two concepts in mind. The first one is termed ischemic width, which basically means the area that's being supplied by the side branch. The second one is the presence of the ischemia. You can have a side branch that doesn't have any ischemia. You don't have to take care of it, even if there is an ostial pinch, as we saw in the earlier case presented today. So the ischemic width and depth is explained in this scenario. So as you can see here, we have two scenarios, one on the left and one on the right. So the first one I'm going to talk about is the one on the left. So you can see this is an ostial left circ, and it has a large area. So this is probably, we all agree that this is a significant and the large and wide ischemic territory. When I compare it to the other one, which is the diagonal, it's relatively a smaller area being supplied by the diagonal. Here are some 4 examples that myocardial perfusion imaging done for them, and they are all positive above 10% of the myocardium, meaning they are clinically relevant side branches. As you can see on the left side, this is about 15% that was assessed by the myocardial perfusion imaging. This is about 15% here, 11%, 10, and 12%. All of those side branches, they are clinically relevant side branch that we cannot leave jailed, and we need further assessment to see what should we do next. So, physiologic-based revascularization decision has 3 concepts that I want to discuss. The first one is the discordance between the angiographic stenosis and the functional significance. The second one is the side branch physiology. When we do a side branch physiology, this will be affected by the upstream and downstream of the disease. So we're not talking about only the side branch, but we are involving the main branch as well. The third concept is the pre-intervention physiology assessment. So let's talk about the first concept, which is the mechanism or the discordance between angio and functional significant. As we can see here, there is a significant geometrical changes between the main and the distal vessel, and you can see the carina here. After stenting, the carina is shifted there. The cross-sectional area is telling you that the carina, although it looks angiographically bad, it is not as bad when we see it in a cross-sectional area right there. So angiographically is bad, but from an IVUS standpoint or a cross-sectional area, it is not as bad. So the second concept is the side branch physiology and influenced by up and downstream. So as you can see, when we put a physiology wire across the diagonal here, this is involving everything down the stream, up the stream. So this is, you can see the step up here, comparing to the ostial shock, which has a significant, impact on the disease. So this is something you have to consider, and you have to discriminate between, lesions, especially the tandem lesions. The third concept, which is the pre-intervention physiology assessment of the side branch. Usually, you cannot reliably predict the functional significance of a jailed side branch. And this will be affected, as we say, by the main vessel stenosis and the geometrical changes with the carina shift. However, this is an important assessment if you are assessing the culprit lesion in a Medina 001, meaning you are only having a side branch disease. In this scenario, it is good to have a pre-intervention physiology assessment. This is just a summary of some clinical studies of the side branch. Again, the bottom line of this is, non-left main, you have less frequent side branch intervention if you do physiology with similar MACE. If you don't want to do a two-stent strategy, probably you should do a physiology to confirm that. This is just a summary of the benefit of the IFR in terms of, short lesion and ostial. You will probably need to do it. However, I would not do it if you have a heavily calcified and severe tortuous vessel. So that's the practical approach. In general, just a summary. If you need to do if the side branch is significant, then you do a provisional side branch or two-stent strategy. Two-stent strategy, we're done. If you're doing a physiology or, a provisional side branch, then you see if there is an angiographic stenosis, you have to go back to the, to the IFR measurement, and based on that, you take your decision. So second part is the imaging and bifurcation. We all know about the role of the imaging for a pre and post. That's something we don't need to talk about just for the sake of time. And OCT-guided provisional stenting is very, very important, especially if you're using the 3D. Unfortunately, we lost a bit of the 3D, but hopefully it's coming back. But this is more specifically important for the side branch wiring pre or post stenting, wiring the distal or proximal part of the stent. A famous October trial that was released 2 or 3 months back at the ESC. That's the most probably important trial for the bifurcation and OCT imaging. It is, just to evaluate OCT in a bifurcation compared to the angiography. It's 1,200, 600 in each arm, 1-to-1, with a primary endpoint of a MACE at a median of 2 years, which is a very hard endpoint. So the clinical relevance is, basically everything except the STEMI within 72 hours, cardiogenic shock, and AKI. That's the primary endpoint, which is a significant composite of cardiac death, target lesion, myocardial infarction, ischemia-driven, revascularization, and this is the protocol. So basically what they did, they evaluated the lesion, before, just for the stent implantation, after rewiring, and, with the final evaluation. This is something that they are looking for in the trial, which is basically optimal lesion coverage, optimal stent expansion, and no stent malopposition with no deformation of the stent. The trial was hardly positive. This is a very positive trial for the bifurcation. But the conclusion from the trial, basically, it lowered the incidence of the MACE, and the second part, which is very important to consider. When you have a patient with AKI, you probably don't want to use a lot of OCT, so maybe an alternative, I would say, IVUS for that. This is another efficacy trial of the bifurcation using IVUS for the non-left main. All of them showed IVUS better outcome. So it is clearly that imaging will help. I'm not going to go into the details of the Illumian, but which was unfortunately a negative trial, at least for the hard endpoint. For the target vessel failure, it was a negative trial, basically OCT versus angiography for everybody, including bifurcation. But the conclusion, as we have multiple studies confirming better imaging and stent expansion, but not hard point yet. This is the conclusion of the 2 years. There's significantly less stent thrombosis, but again, COVID impacted this trial. One thing from a subgroup analysis of the Illumian, unfortunately, even the bifurcation here in the Illumian is negative. So subset analysis of the bifurcation was not positive even in the Illumian, which probably need a lot of probably more studies, and it's still 2A on the guideline. So that's something that we just discussed about the left main. I think it's a very nice algorithm to go over. For if you have a practical distal left main with a stenosis less than 50%, you check the minimal luminal area, and then you just cross over. If it's above 3 to 3.5, then you pot. If you have significant stenosis above 30%, you do the minimal luminal diameter. If it is above 2, then you should be fine. Otherwise, you go with an IFR assessment. Is this something practical to do, physiology, imaging, and blah, blah? I don't know about this on a day-to-day practice, but this is something you definitely should consider. Just to summary, imaging is good for severity assessment as well as the IFR. Involvement of the ostial lesion is good, both imaging and IFR. Imaging is good for calcification, sizing, and optimization. However, side branch compromise after the provisional stenting is the way to go with the IFR and physiology. So in summary, the last 20 seconds, coronary bifurcation are one of the complex lesion subset. As you all agree, practical approach to define functional and clinical relevance of the bifurcation is important. Physiology-guided PCI can reduce unnecessary procedure and related complication. Novel techniques, including CT and myocardial perfusion imaging, will be coming soon. And the last October trial was hardly positive, and we should try to do imaging as much as possible. Thank you.